and welcome to today's webinar. My name is Shirel, and I'm the HoFH patient ambassador and the project lead on HoFH Awareness Day. And I'm thrilled to be co-moderating this event alongside Professor Albert Wigman. Today's webinar is the first of our special trilogy, part of the HoFH Awareness Day campaign, which was celebrated on May 4th. And we're kicking off the series with a focus on genetics because it sets the scene for the following two webinars, and it provides a foundational knowledge needed to understand the treatments that will be discussed in future sessions. Now, the series is also built on the philosophy of collaboration. So the format of the webinar is designed to be interactive with discussions between medical experts and patient experts to reflect the real partnership between medical community and also patients. So thank you for joining us and being part of this conversation, very important conversation. And a special thank you also to our esteemed panelists who have generously taken the time to share their expertise and insights with us, who we will be meeting in a few as well. So before we dive in into the discussion, just a couple of housekeeping notes. This webinar is being recorded and it will be available on the FH Europe Foundation's YouTube channel. And if you have any questions, please post them in the Q&A box and we'll try to answer as many as we can live. However, please avoid any specific questions related to anyone's personal health records or treatment. And we'd also love to hear from you. So let us know who's joining us and where you're from in the chat box. Now, without further ado, it is my pleasure to introduce my co-moderator, Professor Albert Wigman, or Albert, an esteemed pediatric cardiologist and researcher from the Netherlands and a member of the Scientific Advisory Committee of FH Europe Foundation, who will be introducing us to our first speaker. Over to you, Albert.
Thank you, Cheryl. And I'm thrilled to know that there are 3 webinars all dedicated to homozygous FH, a serious disorder. And we will start with Professor Mafalda Bobon. She's a senior researcher at Instituto Nacional de Saúde Dr. Ricardo Jorge, where she is the head of the cardiovascular research group at the Department of Health Promotion and Prevention of Non-Communicable Diseases. And she's specifically interested in the genes, for instance, for FH. And so please, Mafalda, tell us more about your experience and explain where we have many questions afterwards.
Thanks, Albert and Cheryl. It's a pleasure to be here. I will share my my screen now with my presentation. Okay, so it's let's talk about genetics in this couple of minutes. I think one way to start is talking about nomenclature. I'm sure that you have heard in different sites these 3 words: mutation, alteration, and variant. And maybe you thought that they have different meanings, but in fact all the terms are used to address the same. The best way, the way that we use it these days is pathogenic variant, and that means that is a variant that causes a disease, because there's many other variants that they don't cause a disease. So a pathogenic variant is always one that causes a disease. And where do we have that variant? That variant is on the DNA. Our cells have DNA, and that DNA is then transcribed to another molecule called RNA that is then translated to proteins. And proteins is like a group of amino acids. Every 3 nucleotides that you can see here, they will code for 1 amino acid. And this is the real basics of how to code from DNA to protein. So you have an altered DNA with pathogenic variant, you're going to have one of the nucleotides altered, and then you're going to have a different amino acid. So instead of tyrosine, for example, if you have a change in one of these nucleotides, you're going to have another amino acid like glycine or another one. So an altered DNA always gives an altered protein when the variant changed the amino acid, and then if that amino acid changes the function of the protein, you have a pathogenic variant. So a gene has the information to produce a protein, and the gene is composed of several exons. Those exons are the parts that codify for the protein. And then there's also introns that I'm not going to talk about today. And a protein has always a biological role in our body. And if the gene is altered, like I said, then the protein is also altered. And then we have an altered function or activity of that protein. In the case of FH, in the lab, we can measure the LDL receptor activity in percentage, like 0 to 100. And we know that there's 3 genes causing FH, LDL receptor, ApoB, and PCSK9. And all these genes, they code for proteins that are very important to remove cholesterol from circulation. That's why that pathogenic variants in these 3 genes, they cause FH. But 90% of FH patients have variants in the LDL receptor gene. So this is the most important gene in FH. This is just a schematic figure of the LDL receptor, where you can see here the protein with the different domains. That means that different parts of the protein, they have different functions. And then this is the exons, that part that I was saying that then you have the code for the proteins. And it depends on where you have an alteration variant. It depends then the type of variant you'll have. So for example, the most common 50% of LDL receptor variants, they are missense variants. What does this mean? This means that one of those 3 nucleotides that then code for an amino acid, one of these 3 is altered. And then, for example, like you have here, instead of having a G, you have a C, and then instead of an amino acid called alanine, you're going to have a threonine. And this will produce a protein that is produced, but has less activity. So it will have activity between 10 and 70%. And maybe you have heard that these are sometimes called defective alleles. So this is something that you can find in literature. So a variant that has between 10 and 70% of activity is called a defective allele. But then you can have another type of variant, and that is one that also change one of these 3 nucleotides. And instead of having an amino acid here, like example, cysteine, you're going to have a termination codon. That means that the protein will end at this amino acid 681 instead of the 839, because that's the number of amino acids that the LDL receptor has. So when you have a termination codon, you have something called a nonsense variant. And this accounts for 20% of the LDL receptor variants. And when you have a nonsense variant, you have no protein that is produced from that allele, and that is called a null allele. And you can have another type of variants that will just chop out a big chunk of the gene, a lot of exons, like for example here, a deletion of exons 8 to 16. And that is called a large deletion. It's more than 1 exon, and just because it just chops out a big part of the gene, no protein is produced, and that is the null allele as well. And you have 10% of LDL receptor variants that are large deletions. There are other type of variants, but they always fall into these 2 categories, or a null allele where no protein is produced, or a defective allele that still retains some functionality. So let's now talk about heterozygous and homozygous FH. There's a concept that we have to always keep in mind. There is no homozygous FH without heterozygous FH. So the parents of a homozygous patient always have heterozygous FH. Let's see how we represent a family. So scientifically, we always represent a family with squares and circles. Squares are the males and the circles are the females. And you have here, this is exactly the same family, just representing 2 different ways, just for you to understand better. So what is happening here is that the mother has FH. So the mother has a normal LDL receptor gene, and then an LDL receptor with a pathogenic variant. And here is, you can see that we shade half of the circle. It means that the patient is heterozygous FH. And then a couple that has children, in each children has a 50% of probability of having a child with FH. And here as the 4 is represented the 4 options. So the 50% will have FH and another 50% will be unaffected children. Don't look at if they are boys or girls because FH affects both boys and girls. So this is just one example. So let's look at one family with FH. So you have a man with FH. That man has to have parents. In this case, and has inherited FH from the father or from the mother. In this case, inherited from the mother. Then this man married and had 2 children, and both children had FH. Like I said, every child has a 50% chance to have FH. But this man had also had a sister, and the sister had a boy, and the boy did not have FH. So this is one typical FH family. But you can have larger families, of course, and you can have families with myocardial infarction, especially when you have in these families that type of variants that I called before a null allele. Usually in those families, you always have myocardial infarction. So let's go back to nomenclature about homozygous FH. So before, you can probably read in literature, you had 3 types of homozygous FH. They're called true homozygous, compound heterozygote, and double heterozygote. But because this was kind of confusing, now all the forms of homozygous FH are called biallelic. But there are 3 different types. So you have biallelic with identical variants. That means 2 variants and they are identical, 1 from each parent. One, you can have biallelic different variants. So 2 variants, but they are different, 1 from each parent. And this in the same gene. Or you have digenic variants. That means that they come from different genes. And I will show you some examples to understand better these 3 types. And of course, these variants are always in the LDL receptor, ApoB and PCSK9, that they are the FH genes. So let's look at these 2 families. They have homozygous FH with biallelic identical variants. So the one in blue, for example, has this variant that we are going to call it by the protein. So it's a Val 4292Lu. So the father and the mother, they both have the same variant. And then they had 3 children, one that is not affected, one that is a homozygous girl. She inherited from both parents the same variant, and another girl that is a heterozygous FH. So the homozygous FH that has exactly the same variant inherited from the father and from the mother, I know because we have done the studies in the lab that this variant produce 30% of LDL receptor activity. So this homozygote will only have 30% of their LDL receptors active. The other family on the right side, you have a variant called TRIP5772 TER. So TER is the termination codon. So this is a nonsense variant. And it's a nonsense variant, so it's much more aggressive. And you can see here that the homozygous child has less than 2% activity, so has no functional LDL receptor functional in the cell surface. And these 2 different homozygotes will respond to treatment in a different way, because one doesn't have functional LDL receptors, so it cannot be treated with drugs that are dependent of LDL receptor function. Like statins and PCSK9. But the other family with 30% of LDL receptor activity can respond to those treatments because it still retains some LDL receptor activity. So let's see another family, biallelic with different variants. So in this family, the father has an LDL receptor variant, and the mother also has an LDL receptor variant, but they are different. They are 2 different, GLY545 to TRIP and ASP224 to ASP. And they actually have very similar activity. One is about 10% activity, and the other one is less than 10% activity. So the homozygous girl has inherited both variants, both LDL receptor, different variants, and she will have less than 10% activity. So it's going to be actually more severe than this case that I represented here with 30% activity, but very similar to this one that has less than 2% activity. And we have the homozygous with digenic variants. So digenic variants means that they're in different genes. So you have in the LDL receptor gene a variant, ARCH406 to TRIP, and then the father has an ApoB, ARCH3527 to blend. So this is the most common variant in ApoB, and the majority of patients with variants in ApoB, they have exactly this variant. And this variant is known to have 40% LDL receptor activity, and the LDL receptor variant shows 60 to 65% of the LDL receptor activity. So the homozygous girl here, she will have the two variants, one inherited from the father, one inherited from the mother, and it will have LDL receptor activity between 40 and 60. So it's going to be the less severe case that I presented here because of having a higher LDL receptor activity. So just to sum up, FH has two forms, the heterozygous FH that only inherits one variant from one parent that also has high LDL values, and the homozygous FH form. And that means that these persons inherit two variants, one from each parent, so both parents have high LDL and have FH. And you can have three types, the biallelic identical variants, the biallelic different variants, and the biallelic different genes, like I showed you before. But always keep in mind there is no homozygous FH without heterozygous FH, and parents of a homozygous FH always have heterozygous FH. But there's just a very, very, very rare form that with digenic different genes variants, they can come from both from the mother or the father, and the mother or the father will be homozygous as well. But this is a very, very rare case. And like I was saying, you have these three types of homozygous FH, but the most important is the type of variant or variants and its LDL receptor activity. And most treatments depend on the LDL receptor activity, but there are new treatments that are independent of LDL receptor activity. So treatment must take in consideration the LDL receptor activity. We have only about 10% of LDL receptor variants characterized at the functional. So we don't know the LDL receptor activity of all of them. But we have this PERMET project now that we will characterize 1,200 FH variants to know the LDL receptor activity. And this way we will improve diagnosis and treatment that can be then based on the LDL receptor activity. I left many doubts, I'm sure, but I hope I also explained some of the genetic concepts, and I will be happy to take questions after the.
Thank you very much, Mafalda. I quickly hand over to Shira.
Thank you. Yeah, thank you, Professor Mafalda. That was a lot of information to process, and I'm sure we need more than just one webinar on genetics. But it plays a crucial role in understanding the condition and its treatment pathways, and it certainly set the stage for a deeper exploration for this topic. So with that, it's my pleasure to introduce Thanos, our HoFH patient ambassador from Greece. Thanos brings a unique perspective, combining his knowledge of genetics and his insights into the patient journey. So Thanos, over to you.
Thank you very much. I would like to thank everybody that has invested their time to come to this brilliant webinar, the first hybrid for me on this scale. And it's so good to have the opportunity to talk, to serve the stage with scientific expert in genes. So when it comes to genetic testing, to be honest, this was always an alien topic to me, as it is very hard to comprehend, although Professor Mafalda did an excellent job of trying to make it easier for us. I have stayed more or less clueless on the scientific aspect, but as years went by and I moved on to different therapies and had all this life experience with living with HoFH, I started to kind of grasping and understanding the importance of genetic testing in real life situations. I'm going to give you two examples. One of them, it has with me going through trials and trying a new therapy. So I was doing LDL apheresis to where I live. I was doing it for a long time, and I started going and doing my apheresis then in Athens because there were more lipid specialists there, and I had the opportunity to also try new drugs as they were on the trials and see if they bettered the situation for me. But the problem is I had to travel in Athens all the time to give just blood samples. I couldn't do it here because they had to observe me as I was taking the new drug, and then they had to send my blood samples on a different country. So it was imperative that I was there. In the beginning, the test results, the blood results I had were kind of positive, but it turns out in the long run, this drug, me in this trial, I wasn't even meant to be there. Well, obviously, it's no guarantee that a drug will work on you, but the problem is I don't have LDL receptors. I have done the genetic testing previously that it shows that I have zero functionality in my LDL receptors, and the drug I was trying for the patient and for it to work, the patient needs to have some LDL receptors. So I have no problem trying something if it doesn't work. Nobody can guarantee that. But it was really frustrating to realizing that it was failed. It was doomed to fail to begin with. And that was very frustrating. And that's something that goes way beyond my personal experience. If you think that the decisions maker on every country, they have certain resources to allocate, and then you have patients and experts from different fields. You have oncologists, nephrologists, lipidologists. They all are trying to, and also patients, to advocating about securing resources for their own struggles to deal with and have access to treatments. But despite all the differences, the common ground we all share, and I think that everybody can agree on that, that it makes no use to allocating resources and giving drugs to a patient that the drug is going to waste, that another patient would need more. Because although I was in the trial, I'm sure that there are many examples that patients from any condition, really, they're taking drugs that were destined to fail, wasting resources. And not to even mention the point where the patient becomes they don't trust the system anymore, the doctors. They are hesitant to try new treatment. They are not following the treatment because of the psychological impact of not having done it right in the first place, or even in the second. We all know this one person that they have tried many things, and then they turn in disbelief if something new happens because of this. The other point, and I will try to save some time, is that when my father was diagnosed, well, not diagnosed, he went for a blood test before I was born. We didn't know about our condition, and he just made a blood test, and his cholesterol levels was 4 times the maximum normal. And he disregarded the information because he thought that he may ate something the other day, fatty foods, or the machine that made the test is broken. And I'm just wondering if it would be the same if I was being alive at the time, and we had a genetic test, because it's maybe some people would disregard this too, but I think that sometimes it can shake people more to be more active. And when I was born and I was diagnosed and I had the genetic results, it moved my family more to inspire them, my cousins, my grandfathers, to take matters seriously and go and check themselves too. I think that for those 2 reasons alone, and there are many more, I'm sure, it's worth it to advocate for genetic testing. But obviously, my understanding, it only goes that far, and I would like to ask Mafalda, what is your take? What other benefits do you think would derive of that? And why is it important for a patient to know their mutations? And what would we do with all these results once we get the genetic tests?
I think you just said it, Tanos, from you or from your father, then you just identified the rest of the family with FH. So one of the great advantages of having genetic testing is to identify, of course, the index patient, but then after a person in a family has been identified, you can identify very quickly. The test is much quicker, like just some days, and you have a result. The price is much cheaper as well to do the cascade screen in the family. And all of the family can know that they have FH, and they can start treatment as early as possible. The advocate is 8 years old for heterozygous FH. So, and that makes a difference. If a child with FH starts treatment at 8, will grow without cardiovascular disease. But if it's identified at 50 or 40 or 50, maybe, you know, the cholesterol years, they have been accumulating cholesterol for 40 or 50 years. So they probably have a heart attack because of that huge amount of cholesterol being accumulating in the arteries. So it makes a huge difference to identify early and to identify all in the family. So I think the genetics testing for the family is very important. And for the patient, it also, even if the patient is 50, is still a chance to reduce their cholesterol and prevent myocardial infarction and heart attacks. So it's always useful for the patient to know what they have. And then if you do the genetic test, you're going to know the type of variant do you have. If you have a missense variant, a nonsense variant, if you have a functional LDL receptors, if you don't have functional LDL receptors. Of course, sometimes this needs a bit more research, and you need to investigate a little bit more the type of variant, but there's some variants that you already know, like a variant that introduces stop codon or large deletion, like I talked. Those are null alleles. Those homozygous patients with 2 null alleles, they don't have functional LDL receptors, like you said, you don't have as well. And sometimes when you know that, you don't have to go through all the medications that they exist. You go directly to one that works with people that don't have functional LDL receptors. And that's really important. It saves you some time of being accumulating cholesterol and goes directly to the problem. So, of course, we still have to do some research. Like I said, we have this new project, and this project will functional characterize many variants. I think it will change the FH diagnosis. For now, we only have 10% of the variants functionally characterized, and then we have 20% that we know there are null alleles just by the type of variant. But we are still a way to go, and we, from the research side, will continue to work to improve the diagnosis of FH patients, so that this information can be used for your treatment, for your best treatment. I think that is really important.
In line with this, there is a question, do you think that genetic testing should be a routine part of homozygous FH care? And as a homozygous FH patient, how can I know which treatment works best for me? But I think in ways you explained part of it, but is it also something you should routinely do in homozygous FH?
Of course, if you have access, because we know that some countries, they don't have access, so you just have to treat the best way you can that homozygous patient. But if you have access to genetic diagnosis, I think, yes, that you should do it because of this, because then you can choose better the best treatment as soon as possible to give to the patient.
Yeah. Thank you for the moment. I think, Cheryl, we should continue. Or
yes.
Is there time for more questions?
Yes, in the interest of time, we should continue with the second part. And if you, Albert, can introduce our second speaker.
Yes, Professor Steve Humphreys, world-renowned expert in cardiovascular genetics, a field in which he has worked for over 40 years and is still active in, worked at University College of London. And we are very happy that he could join and talk about new developments in gene therapy. Steve, floor is yours.
Albert, thanks very much. So here's an outline of the talk. And I want to declare at the beginning that I'm a consultant for a company called Verve Therapeutics, which is a company based in America, and I'll be talking a lot about the work that they've been doing in this field. So what is gene therapy? Let's just start with that. So gene therapy is changing the genome, the DNA, in the cells of a person to treat their symptoms and prevent the development of a disease. There are a number of important things about this. We only want to change the DNA in the cells of the body where we need to, not every cell. We don't want to change the DNA in the sperm or egg producing cells, so the change isn't passed on to the next generation. And we only want to change the target DNA and not make any other change, because that might increase the risk of cancer. Okay, so how can we use gene therapy to treat FH? Well, as you've heard from Mafalda, we know that mutations in any of 4 genes, and it's primarily the LDL receptor, ApoB, or PCSK9, can cause the clinical pattern of FH. These genes all code for key proteins in the clearance by the liver of LDL cholesterol from the blood. And as Mafalda said, if you've got one of these genes which has an FH-causing variant or a mutation, that's heterozygous FH. And if you've got 2 copies, that'll be homozygous FH. So in theory, replacing the defective gene in every, or at least most, of the liver cells with a working copy will cure FH. So has this been tried? So here's a paper that was published in the middle of the 1990s, so quite a long time ago now. And it was a 29-year-old woman with homozygous FH due to receptor null mutations with very little response to statin therapy. So here's a cartoon of her. The first thing that had to happen was a large piece of her liver, one of the lobes, had to be taken out, obviously a major operation. That piece of liver was then incubated with an enzyme which broke up all the liver into the different cells. These are called hepatocytes. They were put into tissue culture, and they're seen in this little bottle. And then a retrovirus, a virus, was added that includes in it a copy of the human LDL receptor. So clearly that is in order to make the hepatocytes, who don't have any normal receptors, make the normal receptor. So after a couple of days, the cells were collected and then they were injected into a vein, and the hope was that those cells would all go to the liver, migrate to the liver and stay there and start making LDL receptors. Okay, so the first thing is that the patient tolerated the procedure quite well, so that's good. The second thing is that LDL cholesterol did fall by about 17%. Pre-treatment, the LDL cholesterol in this woman was 12.5, so very, very high. Post-treatment, it was 10.4. So you can see that that's actually a reduction, but 10.4 is still very, very high. The good news is that the post-treatment levels remain stable for at least 18 months. So it certainly showed that it was feasible, but it hadn't really cured the problem. The LDL cholesterol was still too high. So there are a number of problems about this whole procedure. It certainly looks like not every liver cell will get a new gene, so there's going to be low overall expression of the LDL receptor. We know that the cells in the liver actually turn over every 6 months or so, so it's possible that in the long term that the effect will fade. And in someone who actually has no normal LDL receptors, if you suddenly make cells make the LDL receptor, the immune system will see this as foreign, and it may then set up an immune response and a rejection of those cells. The same sort of thing if you have a kidney transplantation. So this problem, there's a number of issues here, and what's happened is that no one has really followed this up as far as I know. So is there a better approach? Now, we know that agents that block PCSK9 function have an excellent effect in lowering LDL cholesterol. So in theory, if we could knock out the expression of PCSK9 in the liver using gene therapy, this should be a good treatment. The advantage is we only need one gene therapy agent for all FH patients, whether they've got a mutation in the LDL receptor or ApoB. The disadvantage is it will only work if the patient has some residual LDL receptor activity. Clearly, PCSK9 rescues what receptor activity the individual has. So if it's a null mutation, it's not going to work. So this approach has been tested by Verve Therapeutics in animal models and works well. And I'm not going to tell you about those, but if anyone wants to ask questions, I can give you some information at the end. And it is being tested in an ongoing trial in human subjects with heterozygous FH. And these are the preliminary results that were presented in a meeting in America last November. And what you can see here is that they were using an agent called Verve 101. So obviously it's the first in a series. And you can see there's a lot of authors there, people from Verve, but also a lot of clinicians, both from the UK and from New Zealand, who recruited the patients that were used. And what this what the approach does is use a mechanism called CRISPR that will change one single base in the entire genome and will knock out the PCSK9 gene. It's an amazing piece of work. So this is how they did it. It used what are called nanoparticles to deliver the agent. I got something at the back. And here's a cartoon of the agent. You can see it's a little lipid particle here. And in the middle, there is in red, it's a messenger RNA for a base editing enzyme that will change one adenine to a guanine in the DNA, in the genome. And then in blue, you can see a short guide RNA. It's about 20 bases long. And both of these are very important. So they get infused into an arm vein, just like the patient is getting a blood transfusion. In the blood, the nanoparticle picks up ApoE and then uses the LDL receptor to get into the liver. Once into the liver, the messenger RNA is translated into the enzyme, and both the enzyme and the guide RNA go to the nucleus. In the nucleus, the guide RNA is complementary to a sequence of the PCSK9 gene and only the PCSK9 gene in the whole genome. And so there's only one base that's changed. It's in the PCSK9 gene. 1A is changed to a G, and adenine changed to a guanine. And this spelling change turns off the PCSK9 gene 100%. So the PCSK9 has been completely knocked out. So the aim of this trial is mainly to determine the safety of the procedure, but also to find the best dose. Here's the characteristics of the patients being used, both males and females. All of them had genetically confirmed heterozygous FH, and they had established cardiovascular disease, plus uncontrolled hypercholesterolemia. So even though they were on maximally tolerated oral lipid-lowering therapies, such as statins and ezetimibe, they still had cholesterol that everyone thought was way too high. The trial endpoints were primarily, as I said, safety and tolerability, but they also wanted to look at what are called pharmacokinetics. So how long the Verve 101 agent stayed in the blood. And then they also wanted to know what happened to PCSK9 levels in the blood and LDL cholesterol. And obviously the hope is that both of those will be lowered by the agent. The study duration was 1 year, very intensive follow-up every month or so, with long-term follow-up for safety for another 14 years. So there were 4 different doses. So there are 3 individuals who were dosed with a low dose, some with a slightly higher dose, some with a higher dose. And in fact, there's only 1 individual who got this very highest dose during the trial. So I'm just going to show you a snapshot of some of the results. What you can see here is, and this is 0, so this is the difference on LDL cholesterol from baseline. And you can see that the individuals who got the lowest dose, essentially it was not effective, but it was very safe. There was no side effects here. The individuals who got the next dose had a small lowering, about 10%. So, and again, there were no side effects in this group. So it works, but not very well. In the next highest dose, you can see there were 2 individuals and they had a 39% lowering and a 48% lowering dose, but they did have some mild side effects. And 1 individual had the highest dose, and this individual had LDL cholesterol lowered by 55%. But this individual also did have some side effects. So as expected, I'm not going to show you blood PCSK9 levels were also reduced because the liver wasn't making any PCSK9. And the effects were stable over 180 days, which is as long as the patients had been followed at this point when they reported last November. So the side effects seen in the subjects given the 2 highest doses were of concern, obviously. They were not clinically worrying, and they disappeared after a few days. So it wasn't a major issue, but the company decided that perhaps because of this, the best thing to do was to stop the trial and develop a new, better agent that was going to work better, or even just as good as this, is better, and have less side effects. And so they're now developing an agent called VERVE-102. It's got the same base editor enzyme in the guide RNA, but it's a different lipid nanoparticle. So the particle is actually made of different lipids, which seem to have less side effects. Most importantly, VERVE-102 includes a molecule called GalNAc, which allows the nanoparticle to enter liver cells using either the LDL receptor or a different receptor called the asialoglycoprotein receptor. And what this means is that this will allow much better delivery at lower doses of the agent, which should reduce the side effects. And a trial with VERVE-102 has been approved in both the UK and Canada, and will recruit patients with heterozygous FH or premature coronary artery disease from mid-2024. Okay, so that seems like that's going to be encouraging for patients with heterozygous FH, but what about homozygous FH? If a homozygous FH patient has no LDL receptors to rescue, knockout of PCSK9 won't have any effect. So the question is, can the gene editing strategy be used to knock out a different gene? And it turns out that there is a gene that fits the bill. This gene is called angiopoietin-like 3, or ANGPTL3. It plays a prominent role in the regulation of lipid metabolism. Patients with loss of function variants of ANGPTL3 have much lower levels of LDL cholesterol, and patients with loss of function variants also have much lower cardiovascular risk than the general population. So it really suggests that knocking this out will be of great benefit, and it really should be very useful in patients with homozygous FH. And proof of this was coming from this paper, which was published in 2020. What this group did is they developed a monoclonal antibody called evinacumab, which was against ANGPTL3. They used it in 65 patients with homozygous FH. Overall, the group had a 47% reduction from baseline in LDL cholesterol. And most importantly, and very excitingly, results were similar even among those with LDLR null variants, so with less than 2% LDL receptor activity. So this suggests knockout of ANGPTL3 will lower LDL cholesterol in all homozygous FH patients. So I'm not going to go through this slide in detail. The agent is called VERVE-201. It uses the same methodology as I've already explained, and the trial will initially target 2 different patient groups, those with homozygous FH and those again with refractory hypercholesterolemia with heart disease, and they're not at LDL dose even when they're taking a standard therapy. And the company anticipates starting a clinical trial in the second half of 2024. So watch this space. So gene therapy for homozygous FH, past, present, and future. In the past, replacing the defective gene in the liver using a viral vector was feasible, but had limited LDL cholesterol lowering effect, and it really is not in clinical use at the present time. Presently, gene editing using CRISPR to switch off the PCSK9 gene in every liver cell appears to be safe, at least in the short term, and effective in LDL cholesterol lowering, but clearly it needs larger and longer studies before it become available in the clinic. And while it will be useful in heterozygous FH, it'll only be useful in some patients with homozygous FH. In the future, this gene editing approach is being developed to switch off ANGPTL3, and trials of this agent will be started soon in patients with homozygous FH. If shown to be effective and safe, I think it's hopeful this agent will become available within the next 5 years. And gene therapy obviously offers a once in the life treatment to lower LDL cholesterol and cardiovascular disease risk in both homozygous, in heterozygous FH, and in people who've got high cholesterol, in order to treat them and to lower their future risk. And I'll stop there. Thank you.
Thank you, Steve. I quickly hand over to Shirel for the next speaker.
Thank you. Yeah, so it was a very information-packed presentation, and we definitely, if you have any questions, please make sure to send it in. And now I'm delighted to introduce Michelle Watts from the US. Michelle is an FH and HoFH ambassador and the mother of wonderful Avery, who is living with HoFH. So Michelle, the floor is yours.
Thank you, Sherelle. I want to thank FH Europe for inviting me to speak today and share our story. I'm going to try and very quickly give you a little bit of background about Avery, our daughter. So when my children were little, after going in and completing paperwork over and over work that said we had high cholesterol in our family and we had heart disease in our family, the doctors never said maybe we should test their LDL levels. So after myself doing some research, I decided to ask for them to test the LDL levels. And unfortunately, we learned that our oldest son's cholesterol was over 300, and our 6-year-old daughter Avery's cholesterol was over 800. So immediately, especially for Avery, immediately we were sent to several different specialists, and we ended up seeing a doctor at a hospital, the closest specialist to us, at a hospital 3 hours away from us. She immediately was started on a statin, and he had a suspicion that she had no working receptors. So we had genetic testing very early on to see if he was correct, and he was. She has no working receptor. So that means the treatments available to her are very limited. PCSK9 inhibitors, for example, are not an option. She was, as I said, she was started on statins, and within 6 months, she had her first surgery to implant a permanent port in her chest, and she started weekly apheresis treatments, which took about 5 hours at the time. So those were very long days between the drive and apheresis, and we did that weekly for many years. Now, Avery is slightly different than some of the HoFH patients, or many of them that I've spoken with, as she also has several congenital heart defects. Because of the combination of HoFH and her congenital heart defects, she had her first open heart surgery in January of 2020. Which was quickly followed within the same 24-hour period by an emergency open heart surgery. She also suffered a heart attack in that 24-hour period, and she was 11 years old at the time. Since then, July of 2022, she had her third open heart surgery. And just recently, she's had 2 more surgeries to replace her port in her chest. So with that, I have some questions as a mother of a child with HoFH that I'm interested in learning, Professor Steve. Given Avery's congenital heart defects as well as her HoFH, would gene therapy be an option for her?
Okay, thanks, Michelle. I'm going to say yes, but I'm going to say not yet. As you may have seen, the company are being cautious, obviously, and at the moment they're not considering treating children. The age range of the patients that were recruited into Verve 101, the youngest age was 18. So in any case, which you can understand why. It's partly about informed consent and all these sorts of issues. The concern that you might have as a mother is this treatment safe, and do we have long-term data that it's going to be safe not only next year and the year after, but in 40 or 50 years' time? And the answer, of course, is absolutely we don't. what we do know, of course, as far as we know from the studies that have been done in animal models, there is no evidence of any concern that you might have about cancer or the liver developing some sort of problems. But clearly they're animals and they only live for 3 or 4 years. So the monkeys have been followed up and they're all fine. But we would need human studies in order for this to go ahead. I mean, I think what you could say is, well, okay, by the time Avery is 18, then the studies will have been going on for another 7 or 8 years. So you'd have some much better idea about, is it safe? Are there any issues? So what we can say is we don't believe there will be, but saying that doesn't mean that there might not be something that crops up in rare situations.
Okay. Are there like what are the potential side effects of having gene therapy?
Yeah. So that there are some immediate ones during the infusion, which are and obviously the infusion is done in a clinical trial unit, and the patient is monitored, and they monitor their temperature. So you might get flu-like symptoms. You might get a temperature. Your liver may say, "This is a bit strange." I don't know what's quite going on. And they do occur with these nanoparticles, but they're over within a day. So that if you like, that's a consequence of having all these nanoparticles. And the concern was that in order to get the highest doses, you needed a lot of them, and so the liver might be getting damaged. There is no evidence that that's the case. Long term, yes, the concern would be that as well as changing this A to a G in the right place, it might change it in the wrong place, and then that might increase the risk of cancer. And as I said, in all the studies they've done, they have extremely thoroughly looked using the animals, and there is no evidence that that this gene is changed in any tissue except in the liver, and only in that particular gene and nowhere else in the genome. So it does appear to be very, very specific.
Okay. What about participants that have gene therapy? What about them having children?
Yes. Okay. Well, again, yes. The issue would be whether the agent goes into the ovaries or the testes. And without going into all the details, although perhaps we can talk about it offline. Again, they've used the animal models and they've demonstrated very convincingly that there is no gene editing in either the ovaries or the testes of the animal models that they've looked at. And of course, it would, yeah. So they're as sure as they can be that that's not going to happen.
Thank you, Professor Humphries and Michelle. Due to the short of time, I will now hand it over for Albert to pick some of the questions so we can run over.
Thank you. I saw the question coming in the moment you mentioned, you gave us a high-level talk, Steve, the moment you talked about PCSK9 knocking out, that there were side effects in the highest dose. Can they be reversed?
Oh, the side effects were about platelets. So the person for a day or two had low platelet count, which came back to normal within 2 or 3 days afterwards. And there was no long-term problem. The patient was in the clinical trial unit, so they were taking, I'll say hourly blood samples. They were taking daily blood samples. They noticed this, but there was no bleeding issues. The patient didn't have any clinical consequences because of this. But the company very sensibly said, well, okay, this higher dose seems to have the problem with side effects. We need a better agent. So now with the new agent, they will be able to deliver the dose they need to get a clinical effect, but with a much smaller amount of the actual particle, because it's something to do with the particle itself, not with the gene therapy.
Great. Two questions combining.
Yeah.
One question is it as effective in young as in old? And another question is it if you have already cardiovascular disease, will it then even help?
It's yes, I think the evidence. Okay, there is. As you can imagine, there's not a lot of evidence in humans because there's not very many people that have been part of this trial, but there is no reason to believe that there will be any less effective in younger or older people because it just gets targeted for the liver and will do its job there. And it will be as effective in people who already have cardiovascular disease because it's independent of whether or not you've got a cardiovascular disease. It's just going to go into the liver and do its job.
Yeah. One interesting question is, are gene editing therapies reversible?
The answer to that is currently no. You would imagine that you could reverse it if you had a base editing enzyme that would turn that G back to an A, but that enzyme does not exist. So at the moment, what you would have to say is, no, this is a once in a lifetime change in your liver.
Yeah. I have a question from Mafalda. Why do some people push back against genetic testing?
I was actually writing an answer to that one because I really don't know. Genetic testing is the only way to confirm that you have FH. There's other lipid disorders that they resemble FH, and they are not FH, like cytopeninemia, for example. We have a case here in Portugal that was clinical diagnosis with FH, and in the end, I ended up studying the son, and the son showed a heterozygote variant for cytopeninemia. And when I studied the mother had cytopenia, not FH. And that actually make her health condition much worse because she was treated for a different condition that she was not able to, she was told not to eat animal fat, and she actually has a defect in the vegetable fat metabolism. So it was completely wrong the way they were treating her. So it's really important to know which is the pathway that is affected. Only the genetic testing can do that. And these days, we can test for other lipid disorders at the same time that we're testing FH. And many labs are doing that, at least for the ones that mimic FH phenotype. So I really don't know why people push back against genetic testing. For me, I just see advantages. Of course, there's always the chance of having in your country problems with insurance. I think that's the only reason that I see why not having genetic testing. But there's different movements for countries not being able to use the genetic information of a patient, and I think that is going to be running everywhere because it shouldn't be used. The genetic information is something that you are born with, and you should not use that for insurance. But maybe some countries they do. In Portugal, they are not allowed, but you never know in other countries.
We talked to the insurance companies as well, that people who were testing were becoming older with healthy lives and have access to the newest treatment. But going to the questions, everybody's rather enthusiastic about both your talks and ask what the challenges are for gene therapy or the gene testing. Steve? There is not that much time, but please, the challenges for the gene therapy.
For gene therapy. There seemed to be, initially, the clinicians who were trying to recruit the patients found it hard because it's just such a new idea. And everyone said, well, hang on, is it safe? What will happen? But now that there's some evidence and some data, people are much more enthusiastic about signing up to the trial. And a lot of them say, if this trial will help develop a new treatment for my children, that would be great. And so I think, although there are challenges in getting people to consider joining a trial like this, then I actually think we're now in the stage where those challenges are starting to become smaller.
Thank you so much. I think with that, we'll have to wrap up. As you can see, you cannot fit such an important topic in just 1 hour, but we will have to wrap up this webinar. I want to thank you, Albert, for co-moderating, for Steve, Mafalda, Michelle, and Thanos, and for everyone that their questions was not answered. We will get to that with our post-webinar email, and we will be answering your questions.
Absolutely.
So as we come to an end, I hope that you found this session informative, and also to remind you about our upcoming webinars, which are part of this trilogy. The next webinar, which would be on the golden standards of HoFH treatment, and that will take place on September 19th, followed by a recent trio of the treatment in HoFH on September 26th. So the links to register for these webinars are being shared in the chat. We also have the FH Awareness Day webinar on September 24th. So be sure to mark your calendar and join us for more insightful discussions. Additionally, I want to highlight the HoFH logo competition, that it's still accepting submissions. This is a unique opportunity to showcase creativity and contribute to the identity of HoFH Awareness Day. So we encourage everyone to participate and spread the words. And lastly, a reminder that FH Awareness Day is coming up on September 24th, and it's not too late to join our campaign. You can make a difference by liking, sharing, and engaging with our posts across social media. We also have a toolkit available on the website to assist you in spreading the word. So once again, thank you all for being here, and we look forward to seeing you at the upcoming webinar. Have a great evening, everyone.
Thank you.